Potassium levels and their importance in the body. Normal potassium levels 3.5 to 5.0 MEQL. Potassium, or K+, is the major intracellular cation, essential for maintaining neuromuscular function, cardiac stability, and fluid balance. It plays a critical role in several physiological processes. Key functions of potassium: 1. Regulation of cardiac function and rhythm. Potassium is vital for maintaining normal heart rhythm and electrical conduction. It helps generate action potentials in cardiac muscle. Hypokalemia can lead to arrhythmias such as flattened T waves, U waves, and a prolonged QT interval. On the other hand, hyperkalemia can cause life-threatening dysrhythmias, including peaked T waves, widened QRS, and ventricular fibrillation. 2. Nerve transmission and muscle contraction. Potassium is essential for nerve impulse conduction and the function of both skeletal and smooth muscle. Hypokalemia can cause muscle weakness, paralysis, and cramps. Conversely, hypokalemia can lead to muscle excitability, twitching, or even paralysis. 3. Acid-base balance. Potassium is involved in acid-base homeostasis by shifting between cells and extracellular fluid. In acidosis, potassium moves out of cells, increasing serum levels. In alkalosis, potassium moves into cells, lowering serum levels. 4. Fluid and electrolyte balance. Potassium works with sodium to regulate intracellular and extracellular fluid balance. The sodium-potassium pump maintains resting membrane potential by actively transporting sodium out and potassium into cells. 5. Metabolism and cellular function. Potassium supports protein synthesis and glucose metabolism. It helps in insulin secretion and the breakdown of carbohydrates for energy production. Regulation of potassium levels. Aldosterone, which is produced by the adrenal glands, increases potassium excretion through the kidneys. The kidneys themselves are the primary route for potassium excretion, regulating levels through urine. Additionally, potassium shifts in and out of cells in response to pH changes as part of the acid-base balance. Importance for nurses. Hypokalemia, where potassium levels are less than 3.5 milliequivalents per liter, can cause muscle weakness, paralysis, ileus, and cardiac arrhythmias. On the other hand, hypokalemia, with potassium levels greater than 5.0 milliequivalents per liter, can lead to peaked T waves, bradycardia, cardiac arrest, and neuromuscular impairment. It's really crucial for nurses to monitor potassium levels in patients with renal disease, those on diuretics, receiving IV fluids, or those with acid-base imbalances. Potassium is a vital electrolyte in the body that plays a crucial role in nerve transmission, muscle contraction, and maintaining proper heart function. The normal serum potassium level ranges from 3.5 to 5.0 milliequivalents per liter. Deviations from this range can result in hypokalemia, which is low potassium, or hyperkalemia, which is high potassium, both of which can have severe consequences. Hypokalemia, defined as serum potassium less than 3.5 milliequivalents per liter, can occur due to various reasons. It might result from inadequate potassium intake, excessive loss, or a shift of potassium into cells. Common causes include gastrointestinal losses, such as vomiting, diarrhea, nasogastric suctioning, and laxative abuse. Renal losses can also lead to hypokalemia, with diuretics like loop diuretics and thiazide diuretics being common culprits. Conditions like hyperaldosteronism, seen in Conn's syndrome, and Cushing's syndrome are also notable causes. Potassium can shift into cells due to insulin administration, especially during diabetic ketoacidosis treatment, alkalosis, or the use of beta-adrenergic agonists like epinephrine and albuterol. Inadequate intake from a poor diet or prolonged intravenous therapy without potassium supplementation is another factor. Other causes include excessive sweating and magnesium deficiency, which impairs potassium reabsorption in the kidneys. The signs and symptoms of hypokalemia can be remembered using the mnemonic ASIC WALT. These include alkalosis, shallow respirations, irritability, confusion and drowsiness, weakness and fatigue, arrhythmias such as irregular heart rate, tachycardia, and U waves on ECG, lethargy, and a thready pulse. Other symptoms to watch for are muscle weakness or cramping, decreased deep tendon reflexes, and in severe cases, paralytic ileus, which leads to decreased gastrointestinal motility. Nursing interventions for hypokalemia are crucial and involve several steps. First, monitor vital signs and cardiac rhythm, looking for ECG changes like flat T waves, U waves, and ST depression, and be vigilant for arrhythmias. Second, keep a close eye on serum potassium levels, reassessing frequently, especially if the patient is receiving potassium replacement. Third, administer potassium supplements. Oral potassium is preferred if gastrointestinal function is intact, and it should be given with food to prevent gastric irritation. When administering IV potassium, never give it via IV push, as it can cause fatal cardiac arrest. Instead, infuse it slowly, no more than 10 milliequivalents per hour peripherally, or 20 milliequivalents per hour centrally, and monitor the IV site for phlebitis. Fourth, educate the patient on dietary potassium intake, encouraging the consumption of potassium-rich foods such as bananas, oranges, spinach, potatoes, tomatoes, avocados, and beans. Fifth, monitor for signs of overcorrection, watching for hyperkalemia if potassium is replaced too aggressively. Lastly, address the underlying causes of hypokalemia. If possible, stop diuretics or switch to potassium-sparing diuretics like spironolactone and correct metabolic alkalosis if present. Hypokalemia occurs when there is excessive potassium intake, impaired excretion, or a shift of potassium from the cells into the bloodstream. Decreased renal excretion is the most common cause of hyperkalemia. Chronic kidney disease, acute kidney injury, and hypoaldosteronism, also known as Addison's disease, can all contribute. Certain medications can also lead to decreased renal excretion. These include potassium-sparing diuretics like spironolactone, ACE inhibitors such as lisinopril, and NSAIDs. Increased potassium intake, while rare unless renal function is impaired, can also cause hyperkalemia. This can result from excessive dietary intake or the overuse of potassium supplements. Shift of potassium out of cells can occur due to several reasons. 1. Metabolic acidosis, where hydrogen ions move into the cells and potassium moves out. 2. Tissue destruction, which can happen due to burns, trauma, or tumor lysis syndrome. And 3. Conditions like rhabdomyolysis and hemolysis. Certain medications can also increase serum potassium levels. These include beta blockers, digoxin toxicity, and succinylcholine, which is used in anesthesia. Now, let's talk about the signs and symptoms of hyperkalemia using the mnemonic MURDER: muscle weakness, urinary output decreased, respiratory failure due to muscle weakness, decreased cardiac contractility, which leads to a weak pulse and hypotension. Early signs include muscle twitches or cramps. And finally, rhythm changes seen on an ECG, such as peaked T waves, prolonged PR intervals, widened QRS complexes, and possibly even cardiac arrest. Other symptoms include numbness or tingling, also known as paresthesia, and gastrointestinal hyperactivity, which can manifest as diarrhea and cramping. Nursing interventions for hyperkalemia include the following. First, monitor ECG for arrhythmias. Look out for peaked T waves, wide QRS complexes, and prolonged PR intervals. In severe cases, this can lead to ventricular fibrillation or even asystole. Second, monitor serum potassium levels frequently. It's important to also assess kidney function, including BUN, creatinine, and urine output. Third, take steps to lower serum potassium levels. This can involve administering calcium gluconate or calcium chloride IV to stabilize the cardiac membrane, though it doesn't lower potassium levels. Insulin with glucose IV can help drive potassium into cells. Sodium bicarbonate IV might be used if acidosis is present. Beta agonists, like albuterol, can also shift potassium into cells. Loop diuretics, such as furosemide, can enhance renal excretion. Sodium polystyrene sulfonate, or Kxalate, binds potassium in the gut and is excreted via stool. In severe cases, especially in renal failure, hemodialysis may be necessary. Fourth, restrict potassium intake. Educate patients on low potassium diets, advising them to avoid foods like bananas, oranges, potatoes, spinach, and legumes. Finally, address the underlying causes. This could involve stopping potassium-sparing medications and treating any metabolic acidosis if present. Understanding these conditions is crucial for early detection and appropriate intervention, preventing life-threatening complications. Let's check your memory. Pause the video to give you time to think of the answer to these questions on your own before hearing the answer. 1. Do you recall what the low levels of potassium is? Hypokalemia, potassium levels less than 3.5 milliequivalents per liter. What causes hypokalemia? Gastrointestinal losses like vomiting and diarrhea. Diuretics. metabolic alkalosis, and insulin can all contribute. And some of the symptoms of hypokalemia: weakness, cramps, arrhythmias such as flattened T waves and U waves, and ileus. Do you know some of the interventions for hypokalemia? Oral or intravenous potassium, but never IV push, ECG monitoring, and increasing potassium in your diet with foods like bananas, oranges, and potatoes. So, what is the level of hyperkalemia? Well, it's when potassium levels are greater than 5.0 milliequivalents per liter. What causes hyperkalemia? Renal failure, acidosis, potassium sparing, diuretics. What are some symptoms of hyperkalemia? Peaked T waves, muscle weakness, cardiac arrest. Do you remember what the interventions can be? Calcium gluconate, which stabilizes the heart. Insulin plus glucose, which shifts potassium into cells. And Kayexalate or dialysis. Did you remember them all? Keep practicing to master electrolyte imbalances.